Hi, I'm Jonah Comstock, Editor-in-Chief of Pharmaphorum. I'm here at ASCO 23. I'm joined by Martin Vogel and Ed Chan. They're the EMEA leads for oncology and hematology, respectively, at Janssen. It's already been a long weekend. We're here to talk a little bit about Janssen's news at the show and about some of the trends that these guys are seeing. So thanks for chatting with me today.
Thanks so much, Jonah, for taking the time to speak with us. ASCO EMEA this year are really the most important, the biggest presence Janssen ever had in our 30 year of history in oncology, really developing a lot of very important drugs for the market. Over 90 abstracts, that is what we are overseeing at ASCO EMEA. And yeah, we're happy to share some of the highlights during this ASCO.
Yeah, so give me a couple of the big ones.
So I'll start with solid tumors, and then Ed can follow on with the heme section. So for solid tumors, it's really lung that we're really excited about sharing some first data. And even though the cohort may be small, it's a 20-patient cohort in frontline common EGFR mutant non-small cell lung cancer that received our bispecific antibody amivantamab in combination with our third-generation TKI, lazertinib, for the therapy of those patients. And the data has been really impressive with a median follow-up of more than 33 months. We have not reached to date the progression-free survival, the median duration of therapy, or the overall survival, really highlighting the potential of this combination in this treatment setting.
And what's the mechanism of action there?
There's actually so the idea is that we developed a bispecific antibody that is specifically targeting on the outside of the cell EGFR as a molecule and MET. MET is the MET signaling pathway is a known resistance pathway of first, second, and third generation TKI. So we hope that by blocking the EGFR pathway, not only intracellular at the TKI domain, but combining with the monoclonal antibody, that we can enhance the efficacy.
Great. And Ed, what's going on the heme side?
So for heme side, it's extremely exciting. I think I was talking to Martin earlier. Normally, ASCO is mostly a solid meeting, and now the hematology portfolio is growing, and it's a joint meeting that we now starting doing together. Now, so for hematology, Janssen had really two strong footprints. One area is CLL, and we have multiple myeloma. In CLL, really exciting this year, we're seeing the long-term follow-up of Imbruvica plus venetoclax as a fixed duration in frontline CLL. The 4 years follow-up, at 4 years, the cumulative PFS was 80%. We also demonstrated really interesting data where in this fixed duration, the patients can be retreated with Imbruvica, and we observed that 19 patients been retreated, and 17 out of these 19 patients have Imbruvica restarted, responded. For the myeloma side, it's a huge meeting this year. So we have 4 really impressive compounds in this space. I must highlight the first one is cilta-cel. In ASCO, we will be presenting our results on CARTITUDE-4, which is looking at cilta-cel compared to standard of care in patients who have 1 to 3 prior line therapy. Results are amazing. We're actually showing a significant reduction in the progression by 76%. And not only achieving a really significant better response rate, and we actually achieve much deeper response with over 70% of patients receive cilta-cel reach over complete remission.
And what's cilta-cel? Is that?
It's a CAR-T that we
use as a
BCMA cell CAR-T. In terms of cell therapy, we have 2 more compounds in cell therapy. So the first one is teclistamab, which is the best-in-class BCMA bispecific, which is tailored to patients. It's a weight-based tailored patient, provide the best results we've seen. And in this particular meeting, we're showing really great data that Professor Cohen presented on DIRECT study. It's the first ever study in the multiple myeloma space, looking at combination of 2 bispecific, teclistamab and the younger brother, talquetamab, together in this group of patients, and achieve over 90% of response rate. And this particular study also is why it's so important is we demonstrated the combination of these 2 bispecific achieve over 80% of response rate. in patients who had extramedullary disease. So traditionally, those are really difficult to treat. And we actually demonstrated this combination resolve 80% of patients. The younger brother, tacrolimus. So we're also very exciting. In this ASCO, we're also presenting data on combining daratumumab with tacrolimus in later line patients. Our earlier study, we showed tacrolimus demonstrated really impressive response rate in very late line patients. In this particular study, we demonstrated that by adding daratumumab, we push their response rate even higher. Most importantly, in this study, we also demonstrated 80% of patients who are dara refractory, i.e. the ones who have been treated with daratumumab and refractory daratumumab, actually responded. So daratumumab combination tacrolimus in this study showing signs and data that this combination overcome daratumumab resistance. So you may ask why it's important. It's because daratumumab is now become the frontline pivotal treatment component on frontline multiple myeloma. So as the patient progresses, they need an alternative. And I think this data show that by combining with daratumumab with tacrolimus is really important. The old brother, daratumumab. With this year, we also demonstrated really interesting data, looking at comparing the data in frontline daratumumab, lenalidomide, and dexamethasone versus the kind of traditional standard of care, which is Velcade, lenalidomide, and dexamethasone. We did a match in directional comparison and demonstrating that daratumumab, lenalidomide, and dexamethasone frontline reduces the progression or death by 40% compared to VLD. So really great data, and it was a really good year for Janssen.
Yeah, so you guys said it's a unusually kind of prolific year for Janssen at this conference. What's that a result of? Like, is that just like this pipeline you've been sort of nurturing? Is it everything's blooming at once, or?
So I may start, and Martin, so I think this is a combination of factors. I think we are really lucky and we're blessed. We have very strong pipeline, but I think it's importantly to add is we have really strong support from our patients and from healthcare provider across the oncology space to help us to build this and guide us our development in what to look at and continue working with us. And we are very thankful for that. And Martin?
Yeah, I think it's just the result of our continued efforts to advance the science. So, and honestly, internally, we always say this is the best ASCO, and then the next year we see we're even more successful. So it's not that we are kind of like having how do you say, an exponential growth of abstracts, but it's more a linear, continuous drive towards innovation that we are happy to support.
Right. These events are kind of a snapshot of the innovation that's happening all the time.
Right. I will say, though, that we have been, especially in the solid tumor space, expanded into new disease areas recently. As you can see that the amivantamab data speaks for us entering into the lung space the first time. We are actually advancing into other EGFR MET-driven cancers with the amivantamab program as well. We have shared studies ongoing in colorectal and HCC. So there's a number of things that we hope that we can help patients to benefit from new more precise cancer treatments in the solid tumor space, I would want to say. There's actually in the lung space another abstract there where we look at amivantamab, lazertinib in combination following frontline or second line osimertinib therapy, failing, trying to understand the biomarkers that could predict response to AMI laser combination therapy in a chemo-free setting. So there are lots of abstracts that we are trying to advance the science in the solid tumor space that speak to themselves.
Yeah, it's interesting having both of you here. We talk a little bit about sort of the differences between the solid tumor and the hematology space. It feels like in terms of like where the front edge of the science is, oftentimes things get advanced first in hematology, and then and I'm thinking about cell and gene therapies right now, which haven't really come to solid tumor yet, but some people think like that there is possibility there as we get better at this technology. But I don't know. What do you guys think about how these two spaces sort of interact?
Well, maybe let me start and then you finish off. So I think, well, there are some general statements that may be true, I think. So first of all, we do have to acknowledge that solid tumors seem to be genetically more complex. So and that may make it more difficult to treat. They may also be less less amenable to IO-directed, immune-directed therapies compared to other tumor types in general. At least we have some, for instance, prostate cancer. So it really depends on the, or maybe that's not true. It really depends on the tumor type then when you look at. But especially this complexity, I think, and also the fact from the compartment perspective, heme tumors, the cancer cells circulate through the blood, so it's more easily, if you will, accessible
yeah.
than if you grow in a solid tumor. So and the tumor environment therefore is different and easier to tackle maybe. So there are a number of aspects, I would say, why heme tumors, if you can identify the right target, may be easier to get quicker to high response rates or even cures.
So adding on top of Martin's, I think to me, I think your question is really important. And I think this is a great opportunity for Janssen, where we have the oncology with solid and hematology work extremely closely. And our R&D colleagues also work very closely and really sharing the learning as we progress in developing, right? So every day I'm learning from Martin, how do we identify the right patient? And then when his new compound coming that might be coming from the hematology science side, we'll also help him how we learn and how we can actually build this stronger. So I think to us, this is really important, and I think this will become Janssen's strength and providing help and support to our patients and healthcare provider by sharing and learning together with the two teams.
So I've got one more question for the two of you. I'm trying to ask everybody this. From your perspective working in oncology, how have new technologies like digital and artificial intelligence sort of changed what you do? And how do you see it changing the space going forward in the next 5 or 10 years?
I'm going to address the AI to start, and then Martin, you add. I think, yeah, I'm really exciting about artificial intelligence coming in at the research space. As Martin pointed out, oncology is a very complex disease. And with advance in genomics, we actually want to better understand how does the genetics impact the outcome, and also help us to tailor what therapy would be best for the patient to treat and hopefully cure cancer. The data is vast, it's very complicated, and that's why AI will be extremely useful to help us to analyze and help us to build the next level of patient-focused therapies.
Yeah, it's an excellent question, and we are trying to leverage AI already today. If you think about targeted therapies, the companion diagnostic piece is a huge issue. Getting the test, the turnaround times. So if you were to develop an algorithm, for instance, that could screen standard slides, pathology slides, to try to predict whether or not that patient is a carrier. For instance, FGFR, where we have a late breaker presentation on Monday, that really we feel is going to be practice informing for patients with advanced bladder cancer. It's important to understand and diagnose if that patient has that certain molecular signature that would make him amenable or make him benefit from this targeted therapy. And if you can build an AI engine that can help you pre-screen and identify patients much quicker without having to do the test in every single patient, that's already a huge advancement.
Thank you very much, Martin and Ed. It's really, really appreciate you guys joining me today and giving me a little bit of an update.
Thank you so much. It's a pleasure, and it's a great opportunity to discuss.